Okay, good morning. So, first of all, I would like to congratulate Cloud Physicians for having completed 5 years, and we are currently running the fifth year, having um, um, getting into the new age, I would say. And hopefully things will go great from the academics perspective. Um, so today we'll have a quick discussion about an overview about what ischemic stroke management is from an intensive care perspective. Um, so we'll just have a guideline review today. What is that? Okay. So next. Uh, Today we'll go through the acute management of stroke mainly with thrombolysis, thrombectomies, evidence behind it, what is the hypertension management, antiplatelets and anticoagulation therapy, and some of the look at what the guidelines suggest in terms of managing the complications as well. And uh, to start with, uh, unfortunately, stroke has a huge burden within the country. There's almost about 113 million disability associated life years worldwide, and almost two-thirds of that is within the developing countries itself, with um, and 3.5% of India's disability adjusted life years are lost by because of stroke burden itself. And uh, from a care perspective, at in developing countries, most of the care is managed. Almost 70% of healthcare is managed in the primary health care centers. There's only certain things which can be done in these places compared to what a secondary or a tertiary health center can do. We do talk about having early recognition, pre-hospital management in the resource unlimited countries, but in resource limited countries, there's a lot of time lost in the management of stroke. From the point of problem recognition by the families to the actual management happens. But there are certain things which can potentially be done whenever there is a patient who come to any place, whether they are um, uh, uh, they're able to do the advanced management of thrombolysis and things like that. But at least for any patient who comes, whether he has a stroke or not, some things can be done in intensive care, such as the a newly diagnosed hypertension can be we can do some amount of primary prevention um, by advising about lifestyle changes, tobacco, alcohol use, ensuring that they are compliant with their medications for if they have atrial fibrillation after assessing the risk factors and various other risk factors. Looking through these things, it plays an important role. So from an intensivist perspective, although we cannot do a lot of population-based strategies for primary prevention, any hospital, any patient who comes in with associated risk factors, we can always give them um, we can bring the story into life, into their lives, that they would be I mean, prevention is they are at risk of stroke, and so we need to prevent it. So how do you recognize most patients present with an sudden onset of weaknesses or numbnesses, acute confusions, unable to understand or even speak, and sometimes unilateral or bilateral blindness, acute onset blindness, loss of balance, dizziness, and to the extremes of stroke can even present with seizures or loss of consciousness by itself. So this is something as a which are fairly common presentations in most of the in most of the scenarios. If we have to, we can always recognize these things by having various scales, which will actually help us um, in in our management. So there are many pre-hospital scales, which are all these stroke scales. The pre-hospital scales help in the rapid detection of acute stroke signs. The Cincinnati pre-hospital scale, which is essentially to do with the facial drooping or the arm weakness, or and the speech disturbance, and which are essentially called as the fast. And this is used in many, including India, guidelines do suggest use the face arm speech, the time test. For the time is essentially the duration from which the onset of symptoms happened, for in a pre-hospital setting, to decide where these patients go. If there are availabilities of some sort of communication processes in the place, such as from a tele perspective, or for the pre-hospital uh, in the peripheries, that they must be taken to the most appropriate place where the uh, stroke management can happen, such as secondary and tertiary care hospitals. Then in emergency rooms, when they present to emergency rooms, the Rocher scale, which is recognition of stroke in emergency rooms, also incorporates, apart from these weaknesses and neurological signs, it does incorporate Glasgow Coma scale, the blood pressure, and the blood sugar management, because they form an early part of acute resuscitation or acute management of this patient, and also help in recognizing the non-stroke etiology, which are causing, or the stroke mimics, what we call um, uh, in the emergency rooms. Then we have there's one rapid arterial occlusion evaluation, also part of emergency room test. From the stroke impairment scales, the most commonly used one is the NIHS, or the National Institute of Health Stroke Scale, which assesses the severity and the impairment of stroke in an acute stage. And this scale itself is used for management, for the further management, and deciding whether the patient does fall into the category of advanced management, such as thrombolysis, if there is an ischemic stroke. So the so once we once we finish recognizing these people, we need to have certain specific management principles. Will include to distinguish these strokes from other causes of neurological dysfunction. One of them is is already done by the Rocher test. The and ensure that the treatment is appropriate to what is done. Then you need to determine the pathology, which is the mainstay of management. So to distinguish between a hemorrhage and a ischemic stroke. And since stroke management or time dependent, the importance of this falls quite high. You need to institute most of the disability limiting treatment at that moment, mainly by, if it is a ischemic stroke, it's about thrombolysis, and then if it's about hemorrhagic strokes, then you'll have to start doing everything for secondary brain damage prevention straight away. Then further down the lane, or an important principle of management in the acute phase will end up being the vigilance for complications, which may be any time between the onset of stroke up to almost about 24 to 72 hours. And as time passes, the number of risks for complications reduce, apart from the iatrogenic complications of any intensive care which can happen. Um, so mainstay of evaluation will be CT head, And the rest of the investigations need to be sent off as early as possible for distinguishing, for ensuring that the diagnosis is fairly accurate, and at presentation. So as the patient gets his IV cannula inserted in the emergency room, you can send off all the bloods, and then and send the patient for an so you do. So then average, there is evidence to tell that if you have a door to CT scan time less than around 18 minutes or 20 minutes, then you can CT scan, in the sense not only imaging but also review and ensuring that there is a management plan. Then the outcomes for long-term reduction of disability is higher. Other investigations can wait, lipid profiles, Dopplers, echoes, toxic screens, and things. But one thing from distinguishing the stroke versus stroke mimics should always be about a good history, in history to be taken, so that we rule out other causes such as ethanols and drug screens, etc. So one of the main reason for emergency brain imaging, that is within the 20 minutes, would be to identify the candidates for fibrinolysis or even mechanical thrombectomy, or for both of them. And the concept of ischemic, and this is done mainly to minimize damages in the ischemic penumbra, hypoperfusion, which results in hypoxia and loss of function. Sometimes these penumbras, if you what is seen is even in the core of the stroke, there can be some amount of reversible damage to the ischemic penumbra. The concept actually came up sometime in the 1960s, and over a period of time, this was more and more understood. So if you see in the post post thrombolysis, a lot of this areas of the ischemic regions which were reversible can be salvaged because of early therapy. Um, the problem comes when we have the wake up strokes, when we do not know the onset. That is and the patient goes to sleep well, there was no neurological or signs or symptoms of a stroke, and then wakes up with some neurological deficits. Even in these situations, if the patient, there is some advantage of giving thrombolysis if it is done within 4.5 hours of stroke symptom recognition. So there is the study by God's Thoma et al., which tell that if you have an MRI guided diffusion flare, negative lesions in wake-up strokes, you can still there is some outcome benefit in terms of reduction in the long-term disability with strokes. So what are the mainstays of management we have? We have for thrombolysis, we have alteplase, the tenecteplase, and the streptokinase. Well, I'll just go through evidence and which is the best and which not to be used. So alteplase is, there's very clear evidence of using the alteplase within 4.5 hours. Earlier studies up to almost 2005 or 11 did show that up to 3 hours of it's up to 2008. Most of the studies and the meta-analysis which was done in 14 proved positive benefits of alteplase use within 3 hours of presentation or symptom onset. Then later more studies were have done, and the current evidence from the American Heart Association stroke guidelines is up to about 4 to 4.5 hours after stroke onset. You can thrombolyze patient, which has an equal outcome. In a wake-up stroke, for some amount of improved functional outcome, even 9 hours is utilized, because you don't know the duration. So you would end up giving, but they must have a specific patient selection where they use the MRI, DWI, that is the diffusion weighted imaging, versus the flare mismatch, where there is a diffusion positive but a flare negative. What it means is, in the diffusion, the in the T2 flare images, only uh, the neocortex is very minimally involved, and there's more involvement only around the I think it's around the ventricles. So the radiological assessment and having this particular mismatch will allow better outcomes in wake-up strokes. The second drug is the tenecteplase, which has more evidence. One of the most biggest advantage that it has a longer half-life, and it is a single dose medication, and it is safe. Its safety is comparable to alteplase, although more commonly used medication ends up being alteplase. Streptokinase, which is most easily available, has been studied, and unfortunately, it's not recommended for management of strokes because of increase in the adverse effects. When we talk about outcomes, we are looking at the three months to a 1 year modified Rankin score assessments for them. What are the risks of in these patients? There is always a risk of bleeding. The risk is up to 6.5% with alteplase. The uh, recommendation for giving the alteplase is to be given as early as possible, as soon as the neuroimaging is done, and not to wait for any other blood parameters to be available, especially in those in those patients who have a low risk of either platelet abnormalities or even coagulation deficits, essentially the younger population, less than 60 years, who come into stroke. The giving aspirin as a loading or anything very early on, along if there is a need for thrombolysis or a indication for thrombolysis, actually worsens the risk of having a hemorrhage. So it needs to be avoided at least after the 90 minutes of giving thrombolysis. However, the recommendation of aspirin, I'll come to it later, is once there is a decision to thrombolyze patients, aspirin is not given almost up to 24 hours. So it's given between 12 and 24 hours after thrombolysis. In centers where there is a ability to do mechanical thrombolysis, mechanical thrombectomies, there is a flow chart which can be used for seeing the patient's eligibility for having thrombectomies. If it is within first 4.5 hours, and you have ability to do mechanical intervention, then it can be done within 4 to 5 hours, within 4.5 hours, 4.5 hours. But up to 24 hours in these centers, if there is no availability, or if it's not given for any reason, the chemical thrombolysis, then it can be done. However, so if it is beyond 4 hours and up to about 6 hours, you can still, if you have radiological evidence of anti-circulation strokes, then mechanical thrombectomies are indicated up to 6 hours. If it is beyond 6 hours, up to 24 hours, how it is essentially looked at is, you look at the again a clinical core mismatch as defined by Dawn. and what it means is there's a mismatch between the clinical severity of symptom onset or the deficits and the infarct volume as assessed by neuroimaging. They use automated softwares to look at the DWI on an MRI or a perfusion CT scan, and then decision is made to do a mechanical thrombectomy. Mechanical thrombectomy, along with standard medical care, actually improves outcome compared to even if it is up to 24 hours. That is, the modified Rankin score is better at 3 months. So in posterior infarcts, again, you can consider mechanical thrombectomies as well, but it may need to happen with the ventriculostomies, which I'll come to later. The other important part from a medical management perspective is blood pressure management. If there is hypotension, reasons for hypotension need to be looked at and then managed accordingly. The hypertension is the problem. Most ischemic strokes do present with hypertension, and if the blood pressures are more than 220 or 110, itself is a contraindication for thrombolysis, so we need to bring it down to at least less than 180 systolic and 100 diastolic to give a thrombolysis. So from presentation to thrombolysis, we must use medications such as labetalol or nifedipine or nicardipine or even nitroglycerin to actively bring down the blood pressure and then thrombolyze the patient once it's maintained for some time. The some time is very arbitrary for at least 2 or 3 blood pressure readings, and it must be consistently low. Once thrombectomies are done or thrombolysis are done, for the next 24 hours, the management is to bring down the blood pressure only by about 15% and not to normalize the blood pressure to 140, 80 or less anyway if the patient presents with a higher pressures more than 200 systolic. This is to prevent some areas in the penumbra to become hypoperfused because of loss of pressure gradients in the brain itself. So maintaining vigilance by blood pressure monitoring every 15 minutes for the first 2 hours, then 30 minutes for 6 hours, followed by hourly for the next 16 hours becomes of prime importance. What about DVT prophylaxis? DVT prophylaxis can be given. Intermittent pneumatic compression devices can be used for everyone. Chemical prophylaxis, there is some amount of increased risk of bleeding if it is used within the first 24 hours of thrombolysis, and if the infarct volume is very large and non-thrombolized as well. There's no difference between unfractionated heparins or low molecular weight heparins for to prevent, with respect to bleeding. General supportive measures happen for everyone. Two important features for ensuring brain protection happens would be management of temperature, glucose, ensure that there's normoglycemia and actively maintain to less than 180 milligrams per deciliter. Look for causes of hypothermia and treat. There is no benefit of hypothermias or keeping the patient cold if they are invasively ventilated. Saturations about 94% is plenty. There is no benefit of giving oxygen when the saturation is more than 95%, 94%. Other treatments which are not recommended include hemodilation. Many of the newer neuroprotective drugs have no benefit. So does it cause harm? There's no evidence of major harm, but it's not really recommended as a in the guidelines. Steroids are a no-no for the brain anyway. And drugs such as aspirin or dual antiplatelets, everyone, I mean, we did mention that in the within first 90 minutes of thrombolysis, giving aspirin has detrimental effects in terms of bleeding. Giving it within 24 to 48 hours after the onset of symptoms is what is recommended, with a loading dose of up to 300 milligrams, followed by daily maintenance dose of around 75 milligrams aspirin. Dual antiplatelets, if it is minor non-cardioembolic ischemic strokes, dual antiplatelets are recommended. You can give, I mean, both aspirin and clopidogrel, and the duration for which these are given is as a dual will end up being up to a maximum of maximum of 3 months, based upon the chance and the point trials in the in around 2010 to 15. The aspirin will end up being continued for a longer period of time after changing over from a dual to a after the 3-month period. So in terms of anticoagulation, that is therapeutic anticoagulation, unless there is a DVT, there is no benefit of using therapeutic anticoagulations. There is no difference between and for a prophylaxis, no. It's either heparin or low molecular weight is recommended. So in therapeutic itself, any of the drugs, whether they are heparins or the thrombin inhibitors or the factor Xa inhibitors, have not been shown to benefit purely from a stroke perspective, stroke management perspective. Anti-epileptics, again, it is contextual. Prophylactic anti-epileptics for a week have or for longer periods have no role in the early management, unless there is a patient presence or does have an active seizure. The the next couple of things will be about how to manage acute complications. Brain swelling, there is I mean, it is inevitable to have brain swelling, and the risk is more in larger infarcts and as well as in the cerebellar infarcts and subtentorial infarcts. The It's either medical management or a surgical management. If it is depending upon the severity, everyone gets medical management. There is some evidence to mention about osmotic therapy being reasonable to use, using first mannitol in the first 24 to 48 hours, followed by hypertonic saline to target sodiums of 145 to 155 milliequivalents per liter is can be done. However, we need to look for other reasons for not giving mannitol in view of renal function and other complications from use of mannitol itself. In the more severe acute state, we can use hyperventilation only as a bridge to a definitive surgical management for a very short period of time. But maintaining all this for a longer periods of time is not recommended, or it's not of much benefit. No other diuretics have shown to be of benefit, although some guidelines do suggest that use of furosemide for some national guidelines do suggest use of furosemide um, uh, for as an anti-edema measure is recommended, but the evidence is very poor that and actually there is no uh, I mean, I wouldn't use it personally. Glycerol, there is a short-term benefit of survival, but this studies was done sometime in the 1950s. No evidence of long-term benefits, but this evidence does remain in textbooks, although in journals it's never been studied again. acute complications and surgical management, decompressive craniectomies, younger patients less than 60 years who deteriorate, especially within 48 hours of, I would say, symptom onset as well as completion of medical therapy, do benefit in terms of improved survival, but none of them have actually been able to become independent. Those who get, I mean, no studies have shown independent living at end of 3 months or even 1 year post decompressive craniectomies. For a cerebellar infarcts, as mentioned earlier, and ventriculostomies and decompressions are in addition to decompressotomy is what is recommended. And, due to the fourth ventricle, which gets, I mean, edema, and there'll be hydrocephalus from fourth ventricle. So ventriculostomies are done along with the decompressions. And this ends the topic of what needs to be done from an acute stroke point of view. However, we should not forget that the rest of the intensive care management in terms of the general ICU care, prevention of infection, prevention of pressure sores, nutrition, and physiotherapy and rehabilitation as a part of early rehabilitation as a part of stroke management needs to be initiated when there is stability of the patients. So I would finish all the, this would be the end of the presentation, and we can, any questions or any discussions, open to the forum.
Wonderful presentation, Shashi. The issue always is, we're always sweating the hemorrhagic conversion of these ischemic strokes once we give the TPA. One of the things that I've always had, we're constantly sweating while the altepace is going. Yeah, I mean that it can be as high as 10%, and that's always the fear that we're watching these patients very closely in the ICU and kind of really being very careful and watching for any of the there's a list of things like thrombocytopenia, etc., that put you at higher risk for hemorrhagic conversion of the ischemic stroke. So we have to really keep that in mind. It's so important that we're obsessive compulsive about this and really make sure that we track all this down and make sure that our numbers are there. So that's the one thing I can say, because the bane of my existence is always as an intensivist, when you're dealing with these stroke patients, boy, you're just every little inch you're watching how their exam is changing, and re-examination is a very big part of what we need to keep doing. So that's going to be important.
I just want to add, from a hemorrhagic stroke, the utility of thrombolysis in acute ischemic strokes. I mean, there's a lot of issues in resource limited places in terms of diagnosis, getting the CT scan, ensuring that the CT scan is looked at by a person who is able to look at it. All this can be mitigated by the use of technology to a large extent, but the risk of bleeding and the acceptance by patients or patient families in our country is a huge issue. Why patients do miss out thrombolysis as soon as you mentioned that there is a complication, there is reluctance from a consenting point of view, and that something needs to be done from a public awareness situation, just like myocardial infarctions and then thrombolysis and then better outcomes. That is a point we all
I
should keep in
definitely
mind.
agree. I definitely agree, and it's hard. I mean, but I'll tell you this. That's the other area that we might be able to really impact, is not only the ground crew talking to the family, but having our cloud physician who is also able to talk to the family, can also weigh in. And that's one thing that we started doing a lot of, really, where, one physician, telling the family was not enough to really weigh the balance as far as the family was concerned. What we would say is, would you like to speak to a second individual that can, go over again the risks and benefits so that it can be balanced. The only other thing I wanted to also emphasize to our colleagues is, remember, if they don't get thrombolysis, if they go a little hypertensive, the guidelines for chasing the hypertension, you don't have to be that aggressive. You can allow the pressures to go up a little bit. And I think the threshold is like 220 systolic, 110 diastolic. You're allowed to let it go up, because if you try to bring it down aggressively, the problem is they'll stroke more. So that's something to keep in mind. So again, for our colleagues, as you're managing these patients that don't necessarily, some families will refuse thrombolysis, their pressures will climb. When their pressures climb, don't get too aggressive about, medically managing that hypertension. And that's something to keep in mind. And if you are going to manage it, the safe drugs, nicardipine, labetalol, and amlodipine, but go slow with these drugs, because if you come down like a sledgehammer with these drugs, you can increase the size of the infarct and get your patient into serious trouble.
True.
Good morning. This is Swarna here. I have a comment and a question. Can I go ahead?
Yes, please.
Okay. Comment is, I think when you're transferring patients from one place to the other, it is very important to for example, it's a smaller setup, you're transferring them to a tertiary center. It's always good to just pick up the phone and communicate to the other side so that they're prepared. It's like a stroke call. You've given them a stroke call. So CT is ready or MRI is ready, and the staff are ready for thrombolysis, keep the medications ready if suitable. So I think that would be something which the nursing staff who are here in the group, and of course the doctors, would be really helpful, because we know that earlier the better. I mean, it's time. Yet time is money essentially. So that is number one. And second thing is, the question to you is, what about, we did talk about non-cardioembolic strokes. What about anticoagulation in people who are on who have mechanical heart valves or atrial fibrillation, ischemic strokes? So in such situations, what would be the way to go?
The recommendation from that it's a standard recommendation from as an etiology for the embolism, you need to treat with anticoagulation anyway. So if they have DVTs, you need to treat the DVTs with long-term anticoagulation depending upon why the DVT has happened. If there's mechanical valves, the high recommendation of using anticoagulation, whether it's going to be Comarins or any other anticoagulation. But from a stroke perspective itself, in the early 24 to 48 or 72 hour period, giving therapeutic anticoagulation and thrombolysis at the same time may be detrimental. So you wait until 24 hours after thrombolysis. Anyway, these patients, if they get thrombolysis and drug works for the first 24 hours, mechanical valves or other reasons why there was a stroke is taken care of. So they can, in those patients with definitive indications for therapeutic anticoagulation, it needs to be continued. So most of these is when the confusion happens is when we do not have to give when there is no long-term indication for anticoagulation.
One more comment. COVID and strokes. I think that's a That's again a new thing which are popping up after COVID pandemic. We are seeing a lot of young patients less than 50 presenting with strokes. So that's something which we need to, when we don't find the cause for ischemic strokes, so that is something which we need to think about when we are considering in our differentials.
Yeah. So there is some there is more anecdotal and some evidence to mention that people who have had asymptomatic COVID in the past have presented with various thromboembolic events, but how much of that is of clinical significance and how much it can be directly related is not yet studied. There is no current evidence about that, but yes, the incidence is more recognized with patients with COVID. Symptomatic hospitalized patients with COVID is a different issue again, but asymptomatic and patients who come with thromboembolic events, whether it's PE, whether it's strokes or cardiac or cardiovascular events, is not studied to a great extent at this point of time.
Thank you.